Okay. Good evening, everyone. Welcome to our clinical nephrology upfront webinar. Today, we are going to be having a talk from Prof. Fiziwe Bisiwe on membranous nephropathy, what's new. But before we start, I'm going to just quickly introduce the speaker. So Prof. Bisiwe is a medical specialist who is heading the Division of Nephrology and Kidney Transplantation at Universitas Academic Hospital with a joint staff establishment appointment as an associate professor at the Department of Internal Medicine, the University of Free State, Bloemfontein, South Africa. She is passionate about diagnosing and managing patients with hypertension, kidney disease, and caring for those who are on various forms of kidney replacement therapy. She has a special interest in the treatment of glomerular diseases that are associated with autoimmune diseases and devising ways of breaking barriers to organ donation amongst Africans. She leads the charge in providing supervision for both undergraduate and postgraduate training. With passion for cultivating the next generation of healthcare professionals, her commitment extends beyond the classroom, fostering an environment that encourages innovation and excellence in medical practice with a patient-centered approach. So with that, Prof. Fiziwe, the floor is yours. Thank you.
Thank you very much for that kind introduction, Maza. I'm going to switch off the video and we're going to start. I see people are still joining.
Yeah, that's fine, Prof. You can go ahead.
Thank you. So I'll be talking about what's new in membranous nephropathy. So this is one of the dynamic fields in nephrology that I feel that as a generation of nephrologists practicing at this time, we are so privileged to be part of history making because so much has happened and it is still happening in terms of finding novel diagnostic and therapeutic advances in glomerular disease and more specifically in membranous nephropathy. I've got no conflict of interest to declare. So membranous nephropathy is a glomerular disease pattern of injury that is characterized by immune globulin deposition on the subepithelial space. This leads to disruption of the glomerular basement membrane, damage of the podocytes, and leading to effacement and proteinuria. The actual damage of the kidney is not inflammatory in nature, but it results from the damage of the glomerular basement membrane and the podocyte. There is now new emerging evidence that there is also downstream effects of tubular interstitial inflammation with tubular interstitial atrophy and inflammation and tubular atrophy. It accounts for up to 1/3 of histology diagnosis in patients who are undergoing a kidney biopsy. It is the second most common cause of nephrotic syndrome in adult patients after diabetic kidney disease. Its prevalence is estimated to be about 2 to 17 per million population, but this, as we know, it is not accurate and may be underrepresenting what is happening in Africa. In terms of the pathophysiology of membranous nephropathy, you get a normal podocyte on the left of the screen. And in patients with membranous nephropathy, they've got circulating immunoglobulins, which can be endogenously generated and targeted to an autoantibody, or they could be immunoglobulins that are damaging and binding to the podocyte due to molecular mimicry that they were originally directed to something else, such as in patients who have got infection. The binding of these or the accumulation of these immunoglobulins in the subepithelial space results in cytoskeleton disturbance, which is induced by the antibody binding. And this leads to food process effacement and also generation of free oxygen radicals and damage of the glomerular basement membrane. So the actual inciting agent in membranous nephropathy is quite complex. And as you already know, with the concept of loss of tolerance is very complex in autoimmune disease. One aspect of high-risk genetic fingerprinting entails the genes of the immune system. A study that performed independent genome-wide association studies of single nucleotide polymorphism in patients with idiopathic membranous nephropathy from 3 populations of white ancestry. This comprised 75 French patients, 146 Dutch, and 33 British patients. These were compared and racially matched control subjects, and population stratification and quality controls were carried out according to standard criteria. And this showed that there was homozygous expression of HLA-DQA1 allele on chromosome 6. And this was associated with idiopathic membranous nephropathy with a odds ratio of 78.5. Another study that was done in the East Asian population identified 2 new loci, one in nuclear factor kappa B1 and another in IRF4. Both of these encode pro-inflammatory transcription factors, which suggest that there's a variation of genetic predisposition in between ethnic groups. As we already know, in lupus and other autoimmune diseases, the concept of loss of tolerance is complex, and there's many factors that are at interplay, such as enhanced effector T-cell responses. Some patients display deficiency in T regulatory and B regulatory T cells. There's also some genetic polymorphism in the immune system and podocyte proteins. Some patients end up with membranous nephropathy because of overexpression of podocyte antigens. For example, certain cancers express NEL1 antibody, which leads to overexpression of this antigen and later development of autoantibodies and membranous nephropathy. There is also evidence that there are environmental factors that are at play. A study that was done in China showed that patients who were exposed to air pollution had a 14% higher odds ratio of developing membranous nephropathy after adjusting other confounders such as age. In another French study, membranous nephropathy was found to be more common in patients who worked in construction industry and who had been exposed to toxic materials such as asbestos, lead, and organic solvents compared to the general population. Further research is needed to establish the causality of these environmental factors, and there is a gap in African communities to define whether there are environmental factors that lead to increase the risk of developing membranous nephropathy. In 2002, Debick et al. Identified transplacental anti-neutral endopeptidase antibody-induced membranous nephropathy. This was in a newborn who presented with nephrotic syndrome, and the mother of this newborn had a genetic deficiency of neutral endopeptidase. And this proved target podocyte antigen theory in humans for the first time. There's been a paradigm shift that occurred with the discovery of anti-phospholipase A2 receptor antibodies in 2009 by Beck and his group, where they mixed serum of patients with membranous nephropathy with normal glomerular extract, and they isolated phospholipase 2 receptor from immune precipitants using mass spectrometry. So far, the discovered target antigens comprise about 90% of cases of membranous nephropathy. This slide shows the plethora of other autoantigens and antibodies that have been since described with their associations. And to note, NEL1 is the second common target antigen in membranous nephropathy after phospholipase 2 receptor antibody. It is associated with certain malignancies, specifically mostly solid organ tumors, and in some cases there is a temporal association. It has been described that some patients with positivity of NEL1 antibodies have a history of using indigenous medicines, and it has also been associated with use of non-steroidal anti-inflammatories, lipoic acid, and thiopronin, which is used to treat cystinuria. There's evidence that in the Chinese and Japanese cohorts, there are patients who present with NEL1 positive membranous nephropathy, that is, but without evidence of malignancy. And this implicates race-based differences that need further research and definition. In the Indian populations, about 25% of cases who had NEL1 positivity had a history of using traditional medicines that contain mercury, such as cedar. And up to almost 89% of the cases of the patients who used these indigenous medicines were NEL1 positive, and about 10% of them were also Pla2 positive, and 3% were double positive for both NEL1 and Pla2. And the interesting thing to note is that these patients that had medicine-associated autoantibody positivity went into spontaneous remission after discontinuing the culprit medication. And this implicates that immunosuppression may not be indicated when you find a secondary cause of seropositivity. Do we need to biopsy patients with seropositivity of a known autoantibody known to cause membranous nephropathy? According to the latest critical guidelines, patients with positive anti-Pla2 antibodies that are circulating, presenting with nephrotic syndrome, do not require a kidney biopsy unless they present with an unusual clinical cause, or they've got evidence of an alternative diagnosis or an overlap of other autoantibodies, such as a positive ANA, which could implicate that the patient may be having a class 5 lupus nephritis. Sometimes you may need to biopsy patients who are not responding to therapy, despite the disappearance of circulating antibodies. And this is basically to determine the prognosis and learn the severity of the kidney damage and define whether the patient has got glomerular sclerosis or interstitial fibrosis and tubular atrophy. That will basically help you in terms of guiding therapy. It is also recommended that patients who present with nephrotic syndrome with anti-Pla2 positive antibodies with impaired glomerular filtration rate, specifically below 60 mL per minute, it is recommended that one should biopsy these patients. Other antibodies that have been defined is the thrombospondin 7A, and these appear similarly microscopically when you do kidney histology. They all have diffuse granular IgG deposition, and usually it's your IgG1 and IgG4 that is mostly positive. And in cases where you find deposition that is mostly also in the mesengium and also including C3 and C1q, you should consider other secondary causes of membranous nephropathy that is not usually in keeping with primary membranous nephropathy. In terms of the approach to a patient with membranous nephropathy, the historical clinical approach remains unchanged. And this is because we have seen that even though there has been a discovery of these autoantibodies, they are associated with certain medications, they are associated with certain infections, certain inflammatory conditions, and also malignancies. So it is still appropriate to know whether they are associated to an underlying clinical condition, because the management of the patient will not only entail immunosuppression, but you may need to adjust and treat the systemic disease or withdraw the drug that is a culprit. The other important thing is to note that it's still appropriate to do age-appropriate cancer screening for people who are affected with membranous nephropathy. And this is basically to establish the underlying association and also to plan further management, because it may be inappropriate to prescribe immunosuppression in a patient who has got cancer, who would have benefited from the treatment of the underlying cancer. So this is a proposed terminology of membranous nephropathy. So historically, we know that we've always referred to primary membranous nephropathy and secondary membranous nephropathy, and it then moved to anti-PLA2 positive membranous nephropathy. But then there's still vague description of how we should call this disease. So the proposed nomenclature should describe the pattern of glomerular injury, meaning you should, if your patient has got nephrotic syndrome and on the kidney biopsy, they've got subepithelial immune complex deposits, they've got membranous nephropathy. And then one should stipulate which antibodies have been tested and whether they are positive or they have not been performed, and any clinical association. So the example on the screen is that a patient who has got membranous nephropathy with NEL1 positivity and a coexistence of lung adenocarcinoma would be, the diagnosis would be written as such. And in patients where the antibodies were tested but they were negative, it should be noted on the diagnosis as well. That they were tested and they were negative, and in cases where they were not done, it is still also appropriate to mention that they were not done and whether there was no known disease association. So one thing that is important is to realize that what we are mentioning here is mainly serological testing. And there are also immunohistochemical stains and that one can use in clinical practice. So there is a stain for the phospholipase 2 receptor antibody testing available in clinical practice. And there are cases where patients would have negative circulating antibodies, but when you do the staining on the biopsy, the stain may be positive. And this is due to a sinking effect, because if you have got upregulation of the receptor and with a very high affinity for the autoantibody, the antibody may be drawn into the antigen, and it may be binding there and be undetectable in the serum. So that is still valuable, and it's important to find. So the treatment objectives is to halt the progression of chronic kidney disease, to mitigate the adverse effects associated with nephrotic syndrome, such as debilitating swelling and infections and things like that, or venous thromboembolic disease, and to enhance quality of life by reducing symptoms. Renin-angiotensin receptor antagonists remain the cornerstone of conservative management and managing proteinuria in various glomerular diseases, including membranous nephropathy. But there's evidence that with heavy proteinuria of more than 8 grams a day, the efficacy of RAS inhibition may be impaired, and this supports the approach that we recommend, that patients with heavy proteinuria should be started on immunosuppression and supportive therapy at the same time. As you know, there are other antiproteinuric agents that have been shown to improve to improve outcomes in patients who have got proteinuria, such as the use of non-dihydrobiretin calcium channel blockers, use of mineralocorticoid antagonists, and the new kids on the block is the SGLT2 inhibitors. And on these trials, the DAPA-CKD and the EMPA kidney trials actually did contain about 136 patients who had membranous nephropathy. And in these patients, there was also a positive response that showed that they had improved proteinuria and decelerated eGFR decline. in those who had proteinuric chronic kidney disease. So it is reasonable to include SGLT2 inhibitors when available, although they have not been incorporated in the mainstream KDIGO guidelines. I think at the time of review, those results were not available yet. Beyond the conservative management of antiproteinuric management, one needs to risk stratify patients in terms of their risk to progress for CK to end-stage kidney disease and require dialysis or transplant. Patients who are low risk are those with normal kidney function and mild proteinuria. And it is reasonable to, the other thing that has been included here is the titer of the antiphospholipase 2 receptor antibodies. And if they've got titers of less than 50, that puts them on the low risk category. Those with moderate risk are patients with nephrotic range proteinuria that has not decreased within 6 months by 50% in over a 6 months period, and they've got significant levels of the anti-PLA2 antibodies. And in these patients, it is reasonable to individualize your goals depending on the trends of how the patient has been doing over the previous 6 months and their risk benefit in terms of the immunosuppression. So it is reasonable to still continue watching them for further 6 months or initiate immune suppression if you see that the trends are deteriorating. The patients who are high risk are those with impaired glomerular filtration rate of less than 60 mL per minute or proteinuria of more than 8 grams per day for at least 6 months, or they may have normal kidney function, but with proteinuria that is not decreasing on antiproteinuric medication. And usually their albumin levels is less than 25. They've got a higher titer of anti-PLA2 antibodies, more than 50. And if you are able to measure the urine alpha-1 macroglobin, if it is more than 40 microgram per minute, or the selectivity index of more than 0.2. And these patients who are high risk to progress to kidney failure, and it is recommended that in addition of conservative antiproteinuric medication, one should initiate them on immunosuppression. Very high risk group are patients with life-threatening nephrotic syndrome or rapid deteriorating kidney function, and it is recommended that they are treated and they would be put on the modified Ponticelli regimen instead of the rituximab or CD20 antibodies. So in terms of how you you select, so you will see that on the guidelines, the modified Ponticelli, which entails the cyclical cyclophosphamide that is alternated with glucocorticoids, is equally a first-line drug as with the rituximab, and which regimen you use depends on the patient in front of you, their infection risk, their preference, and which drug you can afford, and basically their risk benefit in terms of the infections and malignancies and things like that. So anticoagulation therapy, we know that membranous nephropathy patients with nephrotic syndrome are at highest risk of having venous thromboembolism. And there's now incorporation of this recommendation about anticoagulation therapy on the guidelines. So patients with serum albumin that is less than 25 should be evaluated for their venous thromboembolism risk. And if they are found to have an increased risk of thromboembolism, they should be evaluated for bleeding risk. And patients who have got an average risk it is recommended that they should be on anticoagulation therapy in form of vitamin K antagonists. Those with high bleeding risk they may be put on antiplatelet therapy such as aspirin and not full anticoagulation. Patients with serum albumin of less than 32, they should be evaluated for arterial thromboembolism risk using a Framingham risk score and the estimated GFR and whether or not they've got other comorbidities that are predisposing them to cardiovascular disease. And if they've got an increased risk, they should be put on antiplatelet therapy in form of aspirin. Those that have got a low Framingham risk score should not get aspirin. In terms of DOACs or the direct-acting anticoagulants, such as factor Xa inhibitors, there's not been robust evidence in terms of studying them in patients with nephrotic syndrome. And the tricky thing is that these drugs are very highly albumin-bound, more than 90%, which makes the pharmacokinetics very unpredictable in proteinuric and hypoalbuminemic states, and therefore it is not recommended. Direct thrombin inhibitors, they're also not systemically studied in nephrotic syndrome. They are, however, less protein-bound than factor Xa inhibitors. And they may be considered a reasonable option in patients with where it's not possible to monitor INR, or that the warfarin is contraindicated and the patient has got increased risk of venous thromboembolism. So this slide summarizes the different drugs that have been looked into and the different approach of which protocol one would use. So as you already know, the modified or the Ponticelli regimen is the oldest regimen that we know it works. However, it is associated with increased risk of infections, and there's also a risk of losing fertility, and also an increase of risk of malignancies with an increased cumulative risk dose over time. So there has been a call for more safer and better tolerated therapies. And up until 2017, and there was, in fact, until the year 2000s, that's when the CNIs were studied and for their efficacy in patients with membranous nephropathy. But at this stage, we were still dealing with the heterogeneous group that was not known whether they are primary or secondary, or they are anti-PLA2 positive or not. And at this point, they compared the efficacy of cyclosporin with cyclical cyclophosphamide in conjunction with corticosteroids, and they were found to be inferior and to be associated with an increased risk of relapse. In 2017, the rituximab was available, and it was compared with supportive therapy, and it was found to it took up quite a long time for patients to achieve remission, but there was benefit of using rituximab. And it then was further compared whether it would be better to combine rituximab with CNIs, and if you compare it with a cyclical cyclophosphamide in combination with methylprednisone, and there was a good effect, and that risk of achieving remission was increased, although it takes long for patients who are on rituximab to achieve any form of remission. So all these studies basically validated that it is reasonable and that rituximab is not inferior to modified Ponticelli regimen in treating patients with membranous nephropathy. So if a patient is low risk, we said we wait and see. Moderate risk, we consider rituximab or a calcineurin inhibitor with glucocorticoids. But in high-risk patients, it is recommended that one uses either rituximab or cyclophosphamide with glucocorticoids, or a combination of a CNI with rituximab. And very high-risk patients are recommended to be on the modified Pondicherry regimen, which it has been shown to be more potent and likely to achieve remission with less relapse rates. In patients who relapse after remission, you individualize your care depending on how they responded initially. So if a patient responded very well to rituximab, it is reasonable to repeat further doses for maintenance of remission. If they did respond well on a calcineurin inhibitor plus corticosteroids, one may consider to add rituximab on that combination. And if they were on a Pondicherry regimen, it may be reasonable to repeat the Pondicherry regimen if you are still within your cumulative thresholds of your lifetime exposure to cyclophosphamide, or it would be reasonable to then switch them to a combination of rituximab plus a calcineurin inhibitor. So sometimes rituximab does not work in some patients. Up to 30% of patients will not respond to rituximab, and this may be due to certain factors. So as we know, this is a chimerized monoclonal antibody. It's not a full, and it may not bind effectively on the CD20 in some patients, and it may fail to deplete the CD20 positive plasma cells. This is one reason, and this can be mitigated by using a fully humanized monoclonal antibody, such as obinutuzumab or ofatumumab, which are more potent and fully humanized, and they don't have an issue with chimerism and binding. In certain cases, patients make neutralizing anti-rituximab antibodies, and this is seen in about 23% of the cases, and this neutralizes your rituximab, and it makes it ineffective, and one must consider switching the medication. And there's also evidence that some patients have tertiary lymphoid structures that produce autoreactive B cells within the kidney. And in such cases, the patients may benefit from an addition of another monoclonal antibody against the B cell activating factor, such as belimumab. And there is also a concept that because rituximab is a protein-bound drug, patients with heavy proteinuria, they may be losing the drug through the urine. And this is thought to explain the reason why the combination of CNIs, which have got an antiproteinuric effect, it seems that they've got an augmented benefit when they are combined with rituximab. In some cases, you get internalization of type 1 anti-CD20 monoclonal antibodies from the surface, and in such cases, it would be beneficial to use the fully humanized auto antibodies. So there's a lot of emerging therapies on the horizon, as it is for many autoimmune diseases out there. So there's trials that are going on obinutuzumab, which is, I've just explained now, it's a fully humanized anti-CD20. It's more potent, and it's likely to work better than rituximab, but we wait the results of the trial. In belimumab, which is a monoclonal antibody against B cell activating factor, which is crucial for B cell activation and survival and production of these autoantibodies. So inhibiting this reduces the production of the autoantibodies. So there's trials that are looking at combining belimumab and rituximab, like we do in resistant lupus nephritis, but we wait the results of the trial. And povetacicept is an enhanced APRIL and BAFF signaling inhibitor, which inhibiting these pathways leads to greater inhibition of B cell populations that are critical for autoantibody formation. This is also in the pipeline in the treatment of membranous nephropathy, and we're waiting for the results to come up. Felzartamab is a fully humanized IgG1 monoclonal CD38 antibody that depletes plasmablasts and plasma cells through antibody-dependent cellular cytotoxicity and antibody-dependent cellular phagocytosis. So this has been approved for some treatment of some plasma cell dyscrasia, and it is now emerging for autoimmune disease, including membranous nephropathy. And the other drug that is in the pipeline is drugs against the complement pathway. So narsoplimab is an anti-MESP2, the manner-binding lectin-associated protease 2 inhibitor. And this is an effector enzyme of the lectin pathway of the complement activation. So if you inhibit this pathway, you may retard progression of kidney disease that's caused by membranous nephropathy. And iptacopan is a factor B monoclonal antibody, which prevents the formation of the alternative pathway C3 convertase. So it is also another possibility of an antiplatelet pathway inhibitor. So the whole discovery of these antibodies and these novel pathways of kidney damage in membranous nephropathy has opened up room, to explore other therapies. And as we can all relate, not all patients tolerate medication differently. So it's always good to have different options. And we're looking for well-tolerated, cost-effective drugs that are likely to induce remission and maintain it for a long time. What do we do in transplant patients? So if a patient, so about 40% of patients with membranous nephropathy have got a risk of progressing to kidney failure. And as we know, kidney transplantation is the most cost-effective kidney replacement therapy that would benefit many patients with kidney failure out there. So we would want to transplant these patients. So if they had a positive anti-PLA2 antibody, one should, timing your transplant, we should always be open and transparent about the risk of recurrence. So in patients who have persistent antibody positivity, they've got about a 50% risk of recurrence. And those that have got negative antibodies, if there is no circulating antibodies and the patient was once biopsied, at the time that they presented, it will always be helpful to retrieve the histology and do the PLA2 antigen staining. And if it is staining positive, but there are no circulating serum antibodies, the risk of recurrence is about 10%. And those that have got negative, the risk of recurrence is about 30%. And you may wonder why. It is probably because the antigen or the antibody is unknown, and the positivity is probably there. It's just that we don't know and we have not tested for it, and therefore there is a risk of recurrence. So knowing that there is a risk of recurrence, it still boils down to weighing risk benefit of what are the benefits of having a well-functioning kidney post-transplant, and the benefits of living without dialysis. We know that those patients have got better survival and better quality of life than patients who remain on dialysis. So it is still reasonable to continue and go ahead with the transplant, but one has to be transparent to the patient, and seeing that there's so many options in terms of the treatment options, I think it is really justified to go ahead and transplant these patients. In conclusion, the landscape for diagnosis and treatment of membranous nephropathy has changed over the last 5 years. Cyclophosphamide-based regimens remain first line for very high-risk disease. Rituximab is superior to CNIs only, and it is at least comparable to cyclophosphamide and glucocorticoid-based regimens for moderate to high-risk patients. And a combination of rituximab plus CNIs may be comparable to cyclophosphamide and glucocorticoid-based regimens. Future therapies will be exploring anti-complement, BAF, fully humanized anti-CD20 and plasma cell targeting, among others, with also anti-plasma cell medications. So what's concerning is that African patients are underrepresented in the studies, and this is a call for action to advocate for availability of appropriate serology testing and histopathology stains at our centers, in that we should advocate for drug availability, which includes antiproteinuric medication, immunomodulatory therapies, and inclusion of African patients in clinical trials. And just to share where I work, we do not have access to SGLT2 inhibitors in the state. One can access SGLT2 inhibitors in private care with extensive motivation. So it's still not a routinely available medication for our patients. So that is the SGLT2 inhibitors. In South Africa, we don't have finerenone registered yet. We still have the old mineralocorticoid that is not selective, that's available to us. In terms of immunomodulatory therapies, in our center, we can now access rituximab for patients with various glomerular disease that have not responded to first-line therapy, or those that the first-line therapy may be associated with unreasonable risk. For instance, patients who already are experiencing multiple episodes of infections, where you would be cautious to want to expose them to things like cyclophosphamide. But it is still limited, our experience, and we would like to be able to access more anti-plasma cell therapies and anti-complement therapies. And the last thing to say is regarding the inclusion of African patients in clinical trials is that our patients are really, these options are not widely available for them, to actually know how do they do on these medications, when they are still on trial, and they may potentially benefit in studies that are, in medications that are efficient. And in terms of the testing, the availability of antiphospholipase A receptor 2 antibody testing, we don't have it in the state sector in South Africa. It's not routinely available. There are centers that facilitate the testing on a case-to-case via private, but with the current economic situation, we are unable to motivate for such testing at this stage. So we really are lacking. We don't know the true evidence, the true incidence and prevalence of the anti-plateau membranous nephropathy in many African patients. And I think we are still stuck there, and it's going to take us more efforts, to move into accessing medications when we can't even agree on the diagnostic testing of these patients. I thank you, and I think we've got time for questions and discussion. Thank you.
Thank you very much, Prof, for that insightful presentation. It was fairly clear. And I completely agree with you. Different areas in the continent have got different challenges. I must say that from our side, when I worked in the state hospital, we also had, difficulty in getting certain stains for, our biopsies. So we could only have light microscopy as part of, our kidney biopsies, which in most cases, will either just show nothing, right, or would show minimal change disease, and then they would just conclude that this is minimal change disease, but it may not necessarily be that. And most of the time, we have patients that are treated at the periphery, where they present with features suggestive of nephrotic syndrome, and everybody treats them as, minimal change disease. They just get steroids, and the patient keeps on deteriorating. The moment the patient gets to a stage where things have now gone overboard, that is when they're referred to a tertiary level hospital. But by the time they get there, we've already missed the boat. And then these patients have to go on to dialysis who are, fairly young. So I believe that testing is very, very important, at least in the Tanzanian context. And I believe other African countries have similar challenges. So I think we need to try and keep our priorities right, and hopefully soon enough we should get this testing done. So with that, there are a few questions in the Q&A box. Prof, would you like me to read them?
Yes, please.
Okay, sure. So the first question is, if antigens are in the podocyte, why are antibodies deposited on the glomerular basement membrane?
So I think so. The antibodies are on the subepithelial space, and that is where the antigens are displayed. That's where your podocyte is facing, basically. So it is the space where the podocytes are facing, and they are not deposited intramembranous in the beginning, as you may already know, that there's different stages of membranous nephropathy. You get first stage up to stage 4, depending on the density of the deposition, whether they are only in the subepithelial space or they even include and destroy the glomerular basement membrane. So they are mainly in the podocytes.
Thank you, Prof, for that clarification. The second question is, did you see or do you see that anti-PLAR2 titers should be added to risk stratification for treatment of membranous? I believe this question was asked before you presented your slide on risk stratification, but perhaps you can just answer.
Yes, it is actually included on the risk stratification. So if it's less than 50, it's falls in within low risk. 50 to 150, it falls into the moderate increased risk, and more than that, it is high risk.
Thank you, Prof. Right, and then the next question is again about the anti-PLAR2R titers. If they are more than 150, do you use rituximab or cyclophosphamide? Again, I believe this question was preempted, but maybe you can just clarify.
So there isn't really solid evidence to use the titers as an individual risk stratification method. So you are using the degree of proteinuria in conjunction with the titers of your anti-PLAR2 with whether or not the GFR is impaired. So it's not used in isolation. And if you look at the trials that evaluated the efficacy of rituximab, you will see that most of the patients, they took very long to actually achieve whether it was partial or full remission. And it took about, I think the median time was 17 months, which is more than a year to actually, for an average patient to achieve partial or full remission. And this is, if you think about it, what does the rituximab do? It stops the marrow from making new immunoglobulins, basically these autoantibodies, but it doesn't do much about the ones that are already sitting on the subepithelial space. And you're achieving the complete or partial remission revolves around dissolution of those antibodies that are already in the subepithelial space. And that space, it's not accessible to many drugs, and it takes long for the immune complexes to dissolve. So I would not from that point of view, I don't think that it's one should think that it's appropriate to use rituximab with very high titers as a only marker. I think it's still reasonable to use the different markers in conjunction and risk stratify your patient, and which medication you use. You also depend on the patient in front of you, their infection risk, their desire to have children, and what you can afford.
Thank you, Prof, for that answer. And the last question on the Q&A, the person is asking cyclophosphamide dosage, is it oral or IV? So I believe it was the studies that were quoted there in the dosages.
So according to the modified Pondicherry regimen, the recommendation is IV methylprednisone for 3 days on the months that you are giving corticosteroids, and the recommendation is 2 milligrams per kg of oral cyclophosphamide. But I do know that there are studies or there are places where IV cyclophosphamide is used in patients where compliance is an issue or the oral medication is not available. But the validated original Pondicherry regimen is oral cyclophosphamide. And that's what I use as well.
Thank you, Prof. Another question is, what do you prefer to monitor response after rituximab, proteinuria or Pla2R levels?
So according to guidelines in the first world where they have got access to anti-Pla2 testing, they monitor both. They check for the decline in the proteinuria and also monitor the titers of your anti-Pla2 antibodies. But in our center, where we fund the testing for anti-Pla2 antibodies from departmental funds, and the test costs around 700 rands per quantitative and qualitative test. So we only use it for diagnostic testing. We don't measure the titers thereafter. And we've had patients that did not respond to rituximab. We've had a young patient that actually intrigued me because she was 18, very atypical age of having membranous nephropathy, and she had positive anti-Pla2 antibodies. And because she's a young girl, I thought it's reasonable to use rituximab in her. And that proteinuria did not budge. She never responded. Beyond a year, her proteinuria was still below more than 8 grams. So we had to switch her to the modified Pondicherry regimen, and she responded well and achieved remission in that. So it's still I think it's a very heterogeneous disease, like many autoimmune diseases, that because there are many pathways that are involved, there's no one size fit all, and sometimes one regimen may not work, or it may be associated with severe side effects that the patient does not tolerate.
Thank you very much, Prof. I don't see any more questions, and we are on time, 5 minutes to 7 in South Africa and 5 minutes to 8 here. So I would like to thank you very much, Prof, for coming on for our clinical nephrology committee for AFRAN for this talk. We thoroughly enjoyed your talk, and it was quite engaging. And would like to invite you again in the future to come through and discuss another topic of your choice. I will contact you soon enough. Otherwise, for everybody else that has joined, thank you very much for joining. We will have another talk next month. Let me just quickly get the date for us. It will be, it's going to be on the 2nd of April, which will be another Wednesday. The topic will be shared on the AFRAN group in due course with the announcement. So thank you very much for everybody. Thank you very much for the host to assist us with all the technical challenges. And I wish you everyone a good evening. And thank you again, Prof. It was nice having you.
Thank you very much. Have a good evening.
Thank you. Bye.
Bye.